Order. Call the meeting to order. This is the Standing Committee on Health. I'm John A. MacDonald, the chair, and the MLA for Hants East. Today we'll hear from witnesses regarding public-private partnerships in healthcare. Just a reminder to put your phones on silent. I'll now ask all the committee members to introduce themselves for the record by stating their name and their constituency, starting with MLA Clark.
Hi, everybody. I'm Braden Clark. I'm the MLA for Bedford South.
Good afternoon and welcome. I'm Rafa Di Costanzo, the MLA for Clayton Park West.
Hi, Gary Burrell, Halifax, Chebucto.
Hello, Susan LeBlanc, MLA for Dartmouth North.
Good day, Nolan Young, MLA for Shelburne.
Good afternoon. I'm John White, the MLA for Clay Spain Dominion.
Good afternoon, everyone. Chris Palmer, MLA for Kings West.
Good afternoon, everyone. Danielle Barcos, MLA for Chester St. Margaret's. For
the purpose of Hansford, I'll also recognize the presence of Legislative Counsel Gordon Hebb and Legislation Committee Clerk Judy Kavanaugh. I think I said it right first that time. I'd like to welcome witnesses, and I'll start by going from left to right. If you just introduce yourself, and then we'll get into opening remarks. Thank you.
Thank you, Mr. Chair. Derek Spinney, Vice President Corporate Services and Chief Financial Officer for Nova Scotia Health.
Good afternoon, Colin Stevenson, Chief System Integration with the Department of Health.
Good afternoon, Kim Barro, Associate Deputy Minister, Department of Health and Wellness.
Hi, I'm Alexandra Rose, Provincial Coordinator for the Nova Scotia Health Coalition.
Good afternoon, Sandra Mullen, President of the NSGEU.
Good afternoon, Colin Audain, President of Doctors Nova Scotia.
Hi, good afternoon. Allison Bodnar. I'm the CEO of the Pharmacy Association of Nova Scotia.
Okay, so I'm going to allow opening remarks. I believe everybody was, due to the number of witnesses, realized to keep your remarks preferably like 2 minutes or under. I guess we'll start with Mr. Spinney. Do you have opening remarks?
I do. Thank you, Mr. Chair. Good afternoon, and thank you to the committee and everyone for having us here today. It's an important time as we all take care of healthcare here in Nova Scotia. Our focus at Nova Scotia Health is always on providing top quality, safety, patient care. To do that, there's almost 30,000 employees here at Nova Scotia Health, and last year our budget would have been over $3 billion. We take that amount of stewardship extremely seriously and work every day with our employees who are very proud to do what they do to provide service to Nova Scotians. Their commitment to patient care, innovation, and quality improvement means we are always refining models of care, trying to find new ways of doing things, being creative, and trying to find the best solution for each and every person we see every day. But neither our government nor our public would be satisfied if we set our sights only on what we can achieve internally. This is one of the reasons why we have created the Nova Scotia Health Innovation Hub as just one example. It brings together partners from many areas to create solutions for Nova Scotians. That's why, where appropriate, we will partner with the private sector to expand and enhance the care that Nova Scotians need and deserve. Any such standards must meet our quality and care standards, and that's very important for us, and that's a non-starter, if you will. That's non-negotiable. The care and experience being at least equivalent or to what would be provided in a Nova Scotia health setting and at no cost to our patients. Private delivery is simply a means to improve the economy, efficiency, or effectiveness of the services that we provide. The best known example of this would be the operating room capacity that we purchase and use at the space next to Dartmouth General Hospital, best known as Scotia Surgeries. The civic address there would be 18 Acadia Street. Through many years and 3 different governments, both patients and surgeons have been very pleased with the quality and timeliness of care that we have been able to provide through that venue. Most recently, the Nova Scotia government has purchased and invested in the facility, enabling us to make more use of those ORs for a wider range of procedures. Our newest such partnership is with Healthview Imaging here in Halifax. Faced with long wait times for MRs, scans, and ultrasounds, we are pulling every lever we can to expand access. We are adding new machines, replacing older ones, and investing in technology that will, for the first time, allow us to move MRI technology to areas of need. It only makes sense that we would simultaneously take advantage of technology that already exists and is staffed to provide more of this same service. Where we see additional opportunities to augment the skills and resources of Nova Scotia Health to provide better, more timely care to Nova Scotians, we will pursue them. I look forward to your questions today. Thank you.
Thank you. Ms. Barro.
Thank you. Thank you, Mr. Chair and fellow committee members, for the opportunity to discuss public-private partnerships in healthcare. I want to begin by stating that in Nova Scotia, we believe in our publicly funded healthcare system. We also believe Nova Scotians deserve the best healthcare in the best facilities, improved access to care, and the tools that will enable and support them to access care closer to home. Our commitment to the public healthcare system is evident in the investments we've made. Investments in new and strengthened collaborative family practice teams, primary care clinics, urgent treatment centers, virtual care, mobile clinics, and community pharmacy primary care clinics, just to name a few. We've invested in physical infrastructure like new clinics, emergency departments, long-term care facilities, a new medical school in Cape Breton, and critical health infrastructure. We are investing and innovating and modernizing healthcare with digital solutions like One Person, One Record, Your Health NS, and e-referrals. We're also investing in people. We are doing new and different things to remain competitive in the current market to recruit, retain, and incentivize healthcare professionals to work and live in Nova Scotia. As an example, we recently announced 30 paramedics from Australia. They're coming here to work. We are following our strategic plan, Action for Health, to transform healthcare in our province, and it's a journey we're not on alone. Managing our healthcare system is a constant balancing act. We must ensure the system is flexible to meet the needs of our province as other factors around it change. Factors like an aging population and a growing population. We've topped 1 million people, and we're still counting in this province. Factors like high demand for skilled healthcare professionals. We address these and other challenges in investing and working with community groups, healthcare partners, and with the private sector. As a province, we've maintained public-private partnerships in healthcare for decades now. Publicly paid surgeons have used privately owned operating rooms for low-risk day surgeries. More recently, more than 1.5 million COVID-19 vaccines doses were delivered through privately owned pharmacies in Nova Scotia. Virtual Care Nova Scotia is supported by Maple, a private virtual care priority. Nova Scotia Health has an agreement with them to deliver the service to Nova Scotians for free. These and other arrangements have allowed us to provide patients health care faster, fairly, and equitably. We don't enter into these partnerships lightly. Any private-public partnership must add value to our healthcare system and come at no extra cost to patients or the province. There is no queue jumping or preferential treatment in our partnerships. Contracts are negotiated to ensure we receive the best value for Nova Scotians, which comes down to more than just a dollar figure. We have pressures across the healthcare system that need to be relieved sooner than later. Public-private partnerships add value, allowing us to deliver more care faster. As the healthcare landscape changes, we will need to be even more adaptable to face the challenges and the pressures. We will do that by continuing to invest in our publicly funded healthcare system and seek opportunities to strengthen it with partnerships that help deliver the care that Nova Scotians deserve. I look forward to taking your questions. Thank you.
Thank you. Ms. Rose. Just wait. There you go. We'll do the same. Don't worry about it. Trust me. There you go. Ms. Rose.
So yeah, I'm here. I'm happy to represent the Nova Scotia Health Coalition. We're an organization dedicated to protecting and strengthening our public health care system to ensure that all Nova Scotians have equitable access to the health care that they deserve. Although we recognize the need for innovation in this healthcare space in Nova Scotia, as we continue to face unprecedented times of backlogs and waitlists within our healthcare system, the Nova Scotia Health Coalition is happy to be a part of this discussion, as it is imperative to recognize potential pitfalls and challenges inherent in blending public and private interests within the healthcare landscape. Justifications for choosing P3 delivery often include giving the greatest certainty for work to be done on budget and on time. P3 delivery offers more government flexibility for continuing with the rest of its capital plan for other projects such as schools and roads. Risks associated with large infrastructure such as healthcare redevelopment and maintenance are transferred to private corporations, and that P3 delivery offers the best value for money. Analysis of past P3 projects abroad in the rest of Canada and here in Nova Scotia have proven that these justifications are often untrue and inflated in favor of P3 delivery. The critical analysis of these justifications has led to P3 delivery being proven to be more expensive, less accountable, and a riskier option than more traditional models. Thank you for inviting me here today, and I look forward to participating in this conversation.
Thank you. Mrs. Mullins.
Thank you. Thank you to the committee. As president of the Nova Scotia Government and General Employees Union, our union represents over 37,000 individuals who help deliver many of the programs and services people depend on. In the last 10 years, the livelihood of many of our members have come under attack with the use of private-public partnerships. In many cases, these partnerships mean loss of public sector jobs. Generally, these contracts are positioned as being done as a cost-saving and efficiency solution. While it makes for an interesting story, the facts don't often check out. In fact, these partnerships are usually done outside the scope of an open and transparent process using what's called alternative procurement process. This was the case for nearly 100 unionized workers when the province wanted to contract out the work of converting personal health records from paper to electronic. The government claimed it would save money and be more efficient to contract the work out. Union took a deep dive into the business case prepared by Nova Scotia Health, found that many of their claims were not to be accurate. The union prepared its own response to the report titled A Matter of Trust, a review of NSH's quiet plan to hand control of Nova Scotians' health information to an American company. The union discovered a discrepancy in the claim of cost savings and found that in the early years the contract there would be no cost savings but a cost increase due to payments required to be made to impacted staff that was not accounted for. In addition, the decision to contract out the complete management and control of every private hospital record for every Nova Scotian to a U.S. company was a matter of critical public interest and was not part of the public disclosure. With the recent privacy breaches throughout the healthcare and civil service, it makes sense to make sure that these security concerns are fully explored. And in the end, NSH pushed the pause button on the private contract, and those 91 people kept their jobs. The main point here is that private-public partnerships have an illusion of cost saving and efficiency, but because they are often done away from public scrutiny, they can be damaging, cost more, and may not be in the best interest of the public. No one should ever have to FOIPOP a private-public contract. This is one example of the many that demonstrate how short-sighted these kinds of contracts can be, and if used, they must undergo fair and open scrutiny. Thank you. Look forward to your questions.
Thank you. Dr. Audain.
Good afternoon. It's my pleasure to join you today. I am Dr. Colin Audain, the current president of Doctors Nova Scotia and a staff anesthesiologist based in Halifax. It will come as no surprise that Nova Scotia's healthcare system is under significant strain with aging human health resources and patient populations. Nova Scotia also struggles with long wait lists for services in many areas. Family medicine shortages and lack of access is straining the system. Until we stabilize the healthcare system, we should carefully consider how we use these limited resources. Doctors Nova Scotia firmly believes that access to health care in Nova Scotia should be based solely on need and not on an individual's ability to pay. We believe in publicly funded health care system that best reflects the values and needs of Nova Scotians. Doctors Nova Scotia is not opposed to private sector involvement in delivery of services as long as those services remain publicly funded and accessible to all. Nova Scotians should not have to pay for health care services from their own pocket. We need to stabilize primary care in the publicly funded system so that all Nova Scotians have good access to the care they need, and this will relieve the pressure across the system. Thank you.
Thank you. And Ms. Bodnar.
Good afternoon. Thank you for the invitation to speak today. There's a lot of attention lately on the privatization of healthcare.
Yet I'm not sure that everyone agrees on what public versus private healthcare is or necessarily the underlying concerns around it. In Canada, we've never really had a fully public healthcare system. It has always been a mix of publicly and privately funded care. While care provided within a hospital setting is generally provided at no charge to patients and considered public, many other critical elements of our healthcare system are not. Psychological care, dental care, prescription medications, ambulances, physiotherapy, optometry are paid by the patients, or if they're lucky, their private insurance. Other parts of our system are publicly funded but privately delivered. Physician clinics, pharmacy walk-in clinics, some surgeries, virtual care, family pharmacare. And even though these providers are small and sometimes large, their funding comes directly from the government. Patients do not pay for those services, and regulators and government have oversight. So what is it that we are worrying about? Leaving aside arguments about the Canada Health Act, I would suggest what we should be concerned about: access. Our system needs to ensure that all residents have access to health care based on need. Equity. As a Canadian, we take pride in our healthcare system and hope that it provides equitable access to care. We must not enable a system that allows patients to bypass publicly funded care by paying for privately available care. We need to create a system that is available to all, regardless of an ability to pay. Cost. We should not be paying more for care by one location or by one provider than another. This means ensuring that services and service providers are appropriately compensated and work environments are appropriate to retain staff. The concept of travel nurses and private relief agencies is a race to the bottom for our public healthcare system. And standards of care. We need to ensure that providers are providing the same standard of care regardless of how they're funded. They must enjoy the same standards of practice, and we need our government and our regulators to enforce those standards. Regardless of how a provider is structured or how their salaries are paid, we need to ensure that there are standards and oversight in place to ensure that there is access, transparency, equity, quality, and cost effectiveness in every service provided. Thank you.
Thank you. So in this thing, we have 20 minutes, 20 minutes, 20 minutes, and for each caucus, and then we'll divvy up the rest of the time in the lightning round. We'll start with the Liberal Caucus, MLA Clark.
Thank you, Mr. Chair, and thank you, everybody, for being here this morning. I just have a few questions, and I believe, and if I'm wrong, certainly whoever's best suited to answer, but I believe this might be a question for Mr. Spinney related to the development of the Your Health Nova Scotia app. Just wondering, do we know to date how much the province has spent on the development of that app?
Mr. Spinney?
Thank you, Mr. Chair. I believe that the information provided before was that it was $12 million.
MLA Clark.
Thank you, Mr. Chair. And is that essentially a set figure at this point, Mr. Spinney, or are there ongoing costs related to that as well?
Mr. Spinney.
Thank you, Mr. Chair. There would be ongoing costs for sure. It's not a static environment. We continue to both plan and develop new applications of how best to use that for Nova Scotians. So one of the examples of that is the trial that's underway right now, for instance, where Nova Scotians can see through the app their primary health care record and what we have in an electronic format from their hospital stay, so blood tests, for instance. So there's a trial underway right now with a limited number of primary care facilities that are participating, and that information has been brought together and made available through the app. So that's one example of what we're doing with it.
MLA Clark.
Thank you. And from a procurement perspective, Mr. Spinney, would these additions or new projects, pilots, whatever they might be, are those all contained within an original agreement and then kind of added on to, or is there separate processes depending on the project? How is that playing out from a procurement standpoint?
Mr. Spinney.
Thank you, Mr. Chair. So the primary care records being joined with the acute care records through the trial is through the arrangement of the vendors that were involved at the beginning. And there's no new procurement for a new thing through that app right now.
MLA Clark.
Thank you, Mr. Chair. Thank you. One of the things that I've heard the Premier and others talk about a lot is how many downloads there have been of the app. And that's one piece of the puzzle. But another thing that I think would be more valuable, we all have dozens of apps on our phone, and we don't use many of them. They just sit there on page 4 of your app screen, and you forget about them. So does the department track not just downloads, of course, but use? So do we know, 20% of users are using it X number of minutes per day? Do we have that kind of data? And if we do, what does that look like, generally speaking?
Mr. Spinney.
Thank you, Mr. Chair. So 2 answers. So yes is the first one, and perhaps we'll take that away to give you a more fulsome answer as well, to share more with it. But just as examples of some things that we're seeing through there, as you said, number of downloads of those health records, for instance, is 1. So we're well over 20,000 now through that, and this is only in the trial period. So we're quite pleased with that uptake. Over 200,000 downloads of the app so far. Both of those numbers, I think, aren't new to the panel here today. And in addition to that, at one point, I'm probably a few weeks out of date now, but there were about 100 interactions a day with the chatbot trying to determine where best to find care, many of those being diversions from the ED, of course. And in addition to that, we see between 400 and 500 virtual care visits being provisioned through that app, through the service every day.
MLA Clark.
Thank you, Mr. Chair. I appreciate that, Mr. Spinney. Perhaps we can do this during committee business, but it might be helpful for the committee to write and ask the department, because it would be helpful to see that breakdown, because I do think there's, as I say, downloads are one piece of it, but use is really, really important. So thank you for that. Just to switch gears here a little bit, Dr. Audain, if I could just ask you about, obviously the meeting is about public-private partnerships, and kind of, as Ms. Bodnar said, it's true that, healthcare in Canada has always been a bit of a mixed bag, in some cases, between public and private services. And in Nova Scotia today, there's a lot of use of maple as an option for people, and I've heard from constituents and others who certainly have used it, and many of them see value in it, and I see why they do. But from your perspective as a doctor and representing doctors in Nova Scotia, what are the mood lighting? Oh, there we go. What are the challenges, I guess, of accessing care through a service like Maple? Obviously, we understand the benefits in terms of immediacy and so on, but what are the challenges, especially when you're not just dealing with a simple, prescription renewal or a one-off case? What do you see from a clinician's perspective that could be a challenge in a use of that kind of service?
Dr. Audain.
Well, I think to answer your question, that virtual care as a concept has been very helpful. It's something that we've leveraged more since COVID, and it allows patients who might not otherwise easily be able to get to a hospital or maybe a specialist because they live in rural places in the province, have access to care that they might not otherwise easily have. To your specific question about a service like Maple, in my mind, it serves as an opportunity for people to have access. It's a bit of a Band-Aid solution in a way. So ideally, what we'd like to see is attachment to primary care providers, and that's not what Maple provides. But when you look at the number of Nova Scotians that don't have access to primary care at all, I think it's a very important service to get access for more patients.
MLA Clark.
Thank you, Mr. Chair. And Dr. Audain, I'm not sure if this is a fair question or not, but it's something that we've heard, is that people using Maple might often say, well, I had an appointment, but I was just kind of referred on to a specialist, and it was not a waste of time, but it didn't get exactly what I wanted. Is there is there a sense that when you're using a service like Maple, you might be getting referred on to someone else more often than you would if you had, attachment to a primary care physician who, you in many cases have a long-standing relationship with? Do you have a sense of that at all?
Dr. Audain.
I don't know if I can say that you're referred on more often with Maple. I don't have any data to support that one way or the other. I mean, certainly there's going to be lots of instances where even if you have an in-person appointment with a family doctor, for example, it will end up with a referral. It's possible that there may be more referrals in a virtual environment because you're not able to do the same type of assessment that you might need in some instances. So it's possible that the referral rate is higher, but I can't say one way or another if that's actually true.
MLA Clark.
Thank you. Thank you, Dr. Audain. And just a question for ADM Barro, if I could. You mentioned in your opening comments OPOR, One Patient, One Record, which is a really important initiative that has been, in the works for many years. Very difficult, expensive and costly. So I'm just wondering, does the department have a timeline or a goal for when we will be able to say with confidence, we've achieved it and we do have One Patient, One Record in Nova Scotia?
Ms. Barro.
Thank you for the question. We do have a timeline for OPOR. There's several milestones that need to be met along the journey. The biggest significant one is next, I think it's January 2025. I would defer to my colleague Derek, with launch in Dartmouth General, and then it goes from there in terms of all of the other facilities, et cetera, to come online. So at the moment, we're on target to meet those deadlines, and we once that kind of gets in the queue, we will be able to see the benefits of OPOR.
Emily Clark, did you want to check with Mr. Spinney on the date, or are you good?
What's that, sorry?
Did you want to check with Mr. Spinney on the date? She referred that he would have.
Oh, yes, sure. Yep.
Mr. Spinney.
Thank you, Mr. Chair. So the date is sometime next spring, so I'm not going to say January. One of the things that we've learned from others that have done this and the partners that we're with is they make sure that we're doing it appropriately as we go through. And so to that end, it's, they bookend months in which you try to implement something, not as specific. They don't try to get that specific because it really depends on where you are in the journey, making sure that all your workflows and the drug formularies and these things are actually in place. And then at the same time, it becomes very specific to the site. So when you enter a site, so the Dartmouth General, as ADM Barro just mentioned, will be the first site. We need to make sure that the site is ready for us at the same time. So it really comes down to even the day of the week, and when we do that, typically it would be a Friday or early Saturday morning, and making sure that the number of surgeries and everything else that's going in the hospital and all those schedules have been adjusted appropriately too. So there's a long way of saying, I guess, that there's a lot of planning that goes into it, but it is next spring for sure. And to expand a little bit further on when will we be able to say we have One Patient, One Record, it is a rollout across the province. So this has never been done before. As far as we can tell, working even with Oracle, our provider, this has never been done that a whole province, one large system where we have 39 plus sites will be going live. So we're actually doing it over 2 to 3 years, where sites will come on, I'll say, one at a time or shortly thereafter. IWK is in the top 3. I can't remember right now if it's the second or third. So it will take us some time to get across the entire province because of the sheer magnitude of what we're doing in Nova Scotia.
Emily Clark.
Thank you, Mr. Chair. I'll pass the mic over to my colleague from Clayton Park West.
Emily D. Costanzo.
Thank you, Chair. And if I may ask, how much
sorry.
time do I have?
9 minutes.
9 minutes. Thank you so much. If I can start with a question to Mrs. Mullen regarding the travel nurses and the capping of hours that that was announced. I just want to know how that has worked so far, if you have any information. We know that other provinces have tried it and hasn't been very successful. So do we know how many hours, or what has happened since the capping? If you can highlight that, please.
Mrs. Mullen.
Thank you for your question. And we speak of this between our colleagues at NSNU, and while we both lobbied strongly for reducing the use on travel nurses, we have yet to see the full impact. We know they are still being used across the province. That is because of an extreme vacancy still existing in many aspects of healthcare, long-term care throughout the province. And I believe at a previous meeting, my counterpart from NSNU spoke on why not allow the nurses in this province to be able to travel within the province to provide coverage where coverage is needed. We have seen, and to be clear, it is a private for-profit situation we're talking about, and public health care. And the private for-profit nurse agency has shown the exorbitant amount of money paid on behalf of that situation, whereas perhaps we could have used monies to fund the programs for nurses here in this province and students in this province to take those programs at a far reduced tuition, if not even free, to make a commitment to work here in this province. So we applaud the fact that they're reducing the hours, but we're not yet ready to be able to fill those positions. So, but it's clear these private nursing agencies are a private for-profit organization, and this is why we want to see more transparency on these agreements, because we've had to really explore and dig deep into that.
Emily DiCasanzo.
Thank you. Thank you for that answer. But we know that in December, there were 350 travel nurses working throughout the province. So how many, I don't know if Ms. Mullen has that information, or the Assistant Deputy would have that information. So do we know how many travel nurses are currently working in Nova Scotia? And has that number reduced since the cap? What was the reduction?
Ms. Barro?
I'm going to defer that answer to my colleague, Colin Stevenson. Thank you.
Mr. Stevenson.
Thank you.
There you go.
Thank you. I don't have a number that's different from the 350. I think our estimate is still that it's approximately 350 or in that range of people who would be agency nurses still working at any given time within the health system, and won't disagree with Ms. Mullen's comments about the desire to actually create the investment within the health system itself. Through people working full-time within Nova Scotia Health, IWK, or within long-term care facilities certainly is the emphasis and the importance that we're placing around a lot of the workforce strategy within the health system. So investments within seats, training and support, development, mentorship, trying to recruit and support people to come from out of province or out of country certainly is where most of the investment and the priority will be. We are seeing some impact on that, and Mr. Spinney may have numbers similar to what I understand, but I know within the past year, I think Nova Scotia Health and the IWK have actually seen a reduction in the vacancies within the health system by just over 400, which is substantive, and great to see that some of those strategies are already starting to pay off, and we're optimistic that that path will continue and the number of agency nurses will continue to decrease.
Emily DiCostanzo.
So do we have any figures, maybe, of what had been used up to the announcement of the cap, and since then? What is the reduction in the dollar value that we have seen?
I'm going to assume Mr. Stevenson.
Yes, sorry. Oh, no. The
day.
financial.
Oh, sorry.
The financial.
Mr. Spinney.
Spinney. I can see the name.
Thank you, Mr. Chair. We can certainly get that. So it's something that we meet literally every Friday on this, so I just don't have it in front of me. So we'll blame the lack of a number on my memory as opposed to really having one. So that's a great question, and we can bring that back to the table. Yeah.
Emily DiCostanzo.
Appreciate to have those numbers. Thank you. My next question will be for PAMS, if I may. I'm just wondering, we know that we have shortage, we're going to have even more shortage of pharmacists. We know we have some already, and we definitely have shortages in pharmacy assistants and pharmacy technicians. What have you seen from government to help reduce or prevent or increase the number of enrollments in those fields, and what has been done since we've met in the last committee meeting and you've announced those? Have you seen any change in enrollment or number of seats or some incentives? So just like for the CCAs to have higher salary for them, so we'll encourage more enrollment for pharmacy assistant and pharmacy technicians and pharmacists as well.
Ms. Bodnar.
Sure, thank you. So we'll start at the pharmacist level. As you know, we haven't filled those classes since the PharmD program came into effect, and part of that relates directly to the tuition. It is now the same cost as medical school. So the return on investment on the other side is substantially different. So we're still looking at things that can be done from a policy perspective, and I can say that there is a standing committee that meets regularly on pharmacy human resources specifically, and looking at what policy levers can be implemented from the student loan programs and loan forgiveness and tuition support in return for contracts of service and things like that. So there is some work underway. I wouldn't say, and there's not been a policy change at the pharmacist level, but there's a lot of work being done from multiple groups. And Dalhousie, I think I can say, is optimistic about filling a class this coming fall. So that's good news. At the technician level, we still see very few enrollments at the technician level, unfortunately. One thing that has happened that is going to help us in that area, however, is the implementation of a bridging program. So to enable experienced assistants to bridge to become a technician, and that took a couple of years, but the approvals and all of that happened, and the first class was launched in March, and so we have 3 full cohorts started in March, another 3 full cohorts already enrolled for June, probably a 4th will fill. That'll bring us in the neighborhood of 300 over 300 technicians on stream within the next 12 to 16 months, which then begs the question of assistance. There is no formal training per se for assistants. It is without, you can come in after high school, lots of kids work in high school and then carry on. So still looking at what opportunities we have as a system to encourage that. And what I can say is the bridging program is one way to do that. So people who come in as assistants who know they have a career path beyond that. But again, there's a lot of work, policy work, there's workplace work, there's remuneration work. All of that has to happen to sort of solidify that workforce for the long term.
Emily DiCostanzo with 20 seconds.
Thank you, and thank you very much for that answer. If you can give us in a very short, what are the numbers that you're hoping to get, whether it's technicians or do you have a plan of numbers that you hope to have?
Mrs. Bodnar.
Sorry, we've estimated that we have a deficit of about 500 pharmacists and pharmacy technicians over the next couple of years. So we're...
Order. Sorry about that. That's at the end of the 20, I have to do that. And the next is the NDP with MLA LeBlanc.
Yep, thank you very much, Mr. Chair, and very interesting discussion so far. I have lots of thoughts and lots of questions, so I'm going to try to stay on track. My first one is for the NSGEU and Doctors Nova Scotia. So we know there aren't enough healthcare professionals. We've just heard an example from pharmacy, but we know it's across the healthcare continuum that we're low on professionals. So with the increasing prevalence of private healthcare clinics or agencies, as we've just talked about with agency nurses, have you seen, and I know you have, because Ms. Mullen, because you've just talked about it, the movement of skilled professionals from the public sector to the private sector? So, no, go ahead.
Ms. Mullen.
Thank you for that question, and exactly that. There are identified over 1,000 vacancies in healthcare in this province. We represent almost 15,000 who work in healthcare, but in immediate healthcare, that's 160 different jobs within the system. None of the procedures can take place without the support of our healthcare folks. They are leaving for private organizations. When you talk about Scotia Surgery, they are working in hospitals in the public side, and they are seeing that the folks who have been referred to these outside agencies are usually the easy ones. But any complex recovery from any of these private situations are referred back to the healthcare system, the public healthcare system. So they're seeing what they have to deal with. The private system is, again, making offers to these folks, taking them out of the public system, which makes our public system very difficult to work in. Staff shortages cause for a number of issues within the workplace. And just like the travel nurses, you know, the morale that has been put in that workplace because your travel nurse is paid far more on an hourly basis than the nurse who is working full-time as a resident here in Nova Scotia, living and paying taxes here in this province. It's very challenging for those folks, and absolutely why they are against that. And while we welcome the reduced hours to that, we need to collectively, and we are doing our part across the country to push that if we can all eliminate the agency part of it and the discrepancy in wages and all of those things. But it's definitely a pull.
MLA LeBlanc.
Dr. Audain, do you have any thought?
Apologize.
It's fine if you don't, because I have lots of questions.
Well,
Dr. Audain.
I guess what I would say to that is, anecdotally, as an anesthesiologist, I have seen nurses that I work with leave to go to other places. But from the physician point of view, I would say there are fewer options to work privately, just because of the way things are generally funded, but because not everything is funded by the public system. You will see movement of people, but more what we see, I think, is if you use family physicians as an example, if you're trying to prioritize primary care, family physicians have a lot of different places they can work in the system. So although it's all publicly funded, if the priority is primary care, those are the things you need to try and work towards and incentivize. Otherwise, people make decisions to go other areas of healthcare.
MLA LeBlanc.
Right, and I would imagine virtual care is possibly, an example of that. So the virtual care situation, in her opening remarks, Ms. Bodnar said, and actually I think Mr. Spinney also said that we need to make sure, with private public partnerships, that we need to make sure that there are no costs to patients and that people aren't paying for health care that is otherwise available publicly. And I would say that in the case of Maple, for instance, I think that's going against what you're saying in that case. So, for instance, I have a family physician, but I get my 2 free Maple appointments, and so I used one of them. If I use a second one, then I understand this has not happened to me, but I understand that I will be offered an opportunity to pay for a subscription to Maple, and I could do that instead of going to my publicly funded family physician, which is exactly contravening what you're saying should be happening. So I guess my question for the Department of Health and Wellness is about Maple. So the contract with Maple to deliver virtual care was initially put in place to serve those on the need a family practice waitlist. We know this. I'm wondering, we've heard from Dr. Audain that it is a Band-Aid solution. Is government funding for this type of private health care a short-term measure or that we can expect to be phased out after we get our ducks in a row in terms of providing attachment to primary care? And is there a timeline that we can expect, or for how long we can expect to be paying for Maple while we are providing attachment to every person in the province?
ADM Barro. Oh, Ms. Barro.
Thank you. Thank you for the question.
Ms. Barro, one more.
Oh,
there we go.
Thank you for the question. What we would say is virtual care is absolutely here to stay. that it's very important that people have all different kinds of access to primary care practitioners. There's lots of people that would rather utilize primary care through a virtual care approach than having to, maybe they don't have a car, maybe they don't have something that would enable them to get to a face-to-face. What I can say is if you utilize Virtual Care Nova Scotia, which we have a contract with Maple to do, then if you need to see a face-to-face person, then there's a pathway into being able to do that. So we're not looking at a timeline to wind back virtual care. We actually feel that it's benefiting patients in terms of access to primary care practitioners, and we're building the appropriate pathways so that if you meet a primary care practitioner through Maple and you need some other type of service, like a face-to-face or specialist or whatever, that those pathways are built. So it's not expected to be out of the envelope of services that Nova Scotians can expect to receive.
Emily LeBlanc.
Pardon?
Emily LeBlanc.
Yeah, so I just want to follow up on that. So I hear you, and I know that I benefited from having a phone call appointments with my doctor, my family doctor during COVID, for instance. It was awesome, and we know that for so many people, it's the way to go. But is that what we're saying? A publicly provided system of accessing your doctor or primary care provider that you are already attached to is very different than the system we have right now with Maple, which is I don't have any attachment. I'm in a real, bad state here. I need some help. And so I'm going to use this system. So for me, when I used my system, I had a lung thing. And, I was real sick and I needed some puffers, but I wasn't going to get to my doctor for 3 months. So it was perfect for that moment. But if that happens to me again or again and again, I have to look at other ways of accessing primary care. So I guess I would like to know if you see that there is a difference between those types of situations. Yes, it's here to stay. It's an important form of accessing your primary care provider, but it's different than filling in the gaps while we wait for everyone to be attached. And I guess I could word that question another way. I guess my question also could be, do you see and does the department see or prioritize attachment for every Nova Scotian in the permanent attachment, as in like to a clinic or a person, maybe not a person, but a clinic in Nova Scotia? Is that still a priority of this government?
Ms. Barro.
Yes, it is. Oh, sorry. Yes, it's absolutely a priority of this department to ensure that all Nova Scotians have access to primary care practitioners.
I said attachment, not access.
Oh, okay. Sorry. My apologies. Okay. Yes, I understand. It's different. Yeah. So yes, that they're actually attached and have the ability to continue to access through that attachment. I'm going to pass over to my colleague Colin Stevenson, as he might be able to talk a little bit more about how virtual care works in that space.
Mr. Stevenson.
Thank you. So to expand a little bit on ADM Barro's comments, I think from a design of the primary care system and where we're certainly trying to go within the province, I think your comment's completely accurate. We're really sort of focused and continue to be focused on ensuring that people are attached to the health system. Like that is the priority for us within the province, and the work that we do with Nova Scotia Health, with primary care leadership, with Doctors Nova Scotia and others, as to how do we actually ensure that that's going to occur. And that can look different for different people. Ultimately, you still want people to be able to get access to the right provider in the way that makes the most sense for them, and that is based on that provider relationship. We do support virtual care in many different means. As ADM Barro has talked about, virtual care in Nova Scotia to provide access to people who don't have as easy access to a regular primary care provider. We also have a virtual emergency care and virtual urgent care, all of which are actually helping to support the delivery of care in their respective environments. Ultimately, we want to make sure that we're finding that balance between how people are accessing through virtual and in-person care. The policy in place within the province actually does require any virtual care provision of service to have a direct pathway to in-person care when it's required. It's It's intended to govern and align with what the standards of care are for the health profession through the college, so it aligns with that, but there is an expectation that anybody providing virtual care understands and has a pathway to refer somebody to an in-person care when they require it.
MLA LeBlanc with just under 9 minutes.
Okay, so a question for Nova Scotia Health. Around the holidays, the winter holidays, between December 24th and January 1st, the available hours for virtual care in Nova Scotia were limited for those without a primary care provider, but unlimited for those with a primary care provider. Can you explain why there were different degrees of availability between the two groups?
Mr. Spinney.
I'm going to return the favor to my colleague, Mr. Stevenson.
Mr. Stevenson.
So just to make sure I understand the question, I believe it was, why would there be a difference between access for people unattached and attached?
MLA LeBlanc.
Yeah. Okay, thanks.
Mr. Stevenson.
So there is a difference between the two services. The Virtual Care Nova Scotia program for unattached is using the Maple platform, but it's delivered by Nova Scotia providers. So they're in the province, so they actually require coverage by those providers in order to deliver to that population. The virtual care for individuals who are attached, you're too free if you want to take advantage of that as a service, is actually based on a partnership agreement between Maple as an organization and their broad national bench of providers and Nova Scotia Health. So if the Virtual Care Nova Scotia schedule, if they didn't have a full slate of providers at that time and able to provide that slate of service, then they could have had a break-in service, which could be unfortunate and doesn't often occur, but that doesn't restrict anybody from being able to access the full bench through Maple for that limited service across the country.
MLA LeBlanc.
So thank you for providing that explanation, but that does, I guess, beg the question, like, what is the rationale between providing or offering people these two frees? I mean, I've already explained that I've used it, and it was convenient because it takes a long time to see my primary care provider, but I could have just as easily, I guess, or almost as easily gone to a walk-in or a mobile clinic. It feels like it's an advertising scheme. Like it's like a way to like get you hooked on this like very convenient thing. And so because you're right, like the provider I had was from Calgary, and I never realized that there was a difference between them. So what is the rationale?
Mr. Stevenson. Right again. There we go.
I think your example is a very good one. I mean, it is intended to actually help provide people with access to care that might not have an option with their own primary care provider. And what they would see is what's available to them is maybe going to an emergency department, as one example. And many of the services, or the intention is low acuity, low risk care that could be satisfied through that type of a service. That is the best place for it, and it helps to ensure that we're not overburdening other parts of the system. So that really is the intention around it. We do know that people who use virtual care services and people who are using the pharmacy walk-in clinics, we know that there actually is a reduction in their visits to the emergency department. They are actually closer to emergency department visits as to anybody who's attached to a provider. So we are seeing a value and a benefit associated with these virtual options and the community pharmacy clinics, where it's actually helping to unburden other parts of the system where we need them to be there to support higher critical care requirements.
MLA LeBlanc.
Can you table that information, that data that you're, I guess, referencing? Like, is there something that you can table? Because that is interesting to me. Like, do we know for sure that because somebody went to a pharmacy clinic, they didn't go to the emergency? Do we have numbers on drops? Because I wasn't aware that our numbers of visits to emergency rooms had dropped substantially since these programs have opened. So I'd love to see that data. But that's just A part. B part is on the Nova Scotia Health's Innovation website, Innovation Hub website, it's noted that many of the virtual care appointments delivered through Maple subsequently did result in in-person visits. So can you clarify what that means? My colleague asked a question, and I think he was suggesting that they resulted in referrals to specialists, but I'm wondering if you can speak to the number of people who use Maple and then are referred to an in-person primary care visit.
Mr. Spinney. I believe.
Thank you, Mr. Chair. So yes, and we'll get more specific numbers too. I'm going to give you a range though, just to paint the picture. So between 10 and 20% of the time, when the 400 plus people a day that I mentioned are using virtual care every day on the unattached list, between 10 and 20% of those were not being able to resolve their question in that session. And so what we then do is we provide them the pathway, as someone mentioned earlier, into one of the primary care collaboration centers. And you'll start to hear us use words like health home, for instance. And this is to your earlier question about connections and attachments, I think is the word you used, trying to help people understand how they're being attached to the system and to a place where they can call back. They may not get the same physician, but they, I'm going to say people know them there because it is their health home, their record is there, we understand that. So between 10 and 20% of the time, they're referred to an in-person visit. We place them, take care of that for them, make the appointment at the primary care place, and then they can go in and they see somebody in person. And then from there, they may end up being referred on to a specialist as well. But that's the pathway as it is right now, yes.
Emily LeBlanc with just under 3 minutes.
Okay. Thank you. That's helpful. So back to the data question. I'm wondering if the department has, or Nova Scotia Health has developed any metrics to, to ensure effectiveness. So, like, what are all of the sort of things you're looking at to know that this is working, basically?
Mr. Spinney? Or
Thank you, Mr. Chair.
Stevenson, which one?
You start.
I'm going to start,
okay.
And then quickly hand it off. So we absolutely do. So one of the things, we're very data-driven. Our chief data officer is actually sitting behind me, so I'll put in a commercial for Mr. Murphy as well. But so yes, we do, and the Innovation Hub has evaluation teams that go in and they look at this. So unfortunately, I don't have those 6 or to 10 metrics to actually share with you today with the values, but I think that that's something great that we should submit back to the table because there are absolutely key performance indicators that we're tracking to make sure that we're actually hitting the mark.
Emily LeBlanc, do you want Mr. Stevenson?
No, that's okay.
Okay.
Sorry,
Emily LeBlanc.
no offense. I guess I'll just quickly ask with the time I have left in this round. Again, many of you talked about the importance of quality of care in your opening comments. For things like pharmacy appointments or perhaps virtual care or even travel nurses, how do we make sure that the quality of care is there? Like, are there audits done? Are there checks and balances in place? What is happening to make sure that people are getting the care that they deserve and need?
Okay, with 54 seconds, who wants to try that one on? ADM Barro.
Okay. So first of all of those practitioners that you mentioned would be regulated health professions. So they actually have, through their licensure, the expectation of quality of care within the standards and ethics and all the pieces that would back them as regulated health professions. I can't speak to the contracts specifically around those, but I would say that in terms of like public protection for practice of care, that would be the relationship of that person if they had a complaint back to their college, and that should be followed up. So that's one. We would hire licensed professionals in all of those instances to ensure quality of care. Emily
LeBlanc with 5 seconds.
Thank you so much for answering my questions.
Thank you. Emily Young. Oh, sorry. Emily White?
White.
Sorry.
Thank you, Chair. So my questions are to the department and to Nova Scotia Health. So we realize that the problems is facing aging population growth, and of course the shortage of healthcare professionals. I just wonder if you could take a few minutes to help us explain how the province is adapting to these challenges, and more specifically, how the public-private partnerships are a solution to any of this.
ADM Barro?
Yeah, sure. I'll take a kick at it, and I might invite my colleagues after. So just to step back, we've always had public-private partnerships. So in terms of our relationship with doctors has always been through a public-private partnership. Many of doctors are incorporated, so this is not new. But to address the issues of a growing population, the aging population, and the fact that we have a shortage of healthcare professionals, we need to utilize the assets and the infrastructure that public-private partnerships enable us to do. So it's a wave of the future that we really have to capitalize on all of the assets that we have in Nova Scotia. As an example, the relationship with HealthView, where we're buying more MRIs and other diagnostic imaging, enables us to address the huge wait lists that we have. I'm sure you know that we're also receiving clawbacks from the federal government because we are allowing sort of HealthView to operate. But this way, we're actually buying more seats, addressing the wait lists, and probably satisfying federal government's requirements for ensuring that we have publicly funded. We can't stop a company like HealthView to operate, but what we can do is enter into a partnership that allows us to buy the assets that we need to address the concerns at no cost to the Nova Scotian. We are by no means entering into any public-private partnerships that require public to pay out of pocket for any of these services. So we're utilizing that asset as opposed to building costing us more to build that type of infrastructure. HealthView has it already, and we're buying assets from them, as an example.
Emily White.
Thank you. Thank you very much. So when some people hear public-private partnership, they assume it means privatization of services, right? And unequal access is what it means to some people. So I'm wondering if you can help clarify how it actually works.
Audain Barro.
Right. So a private service would be one that is not paid for by government or under our Provincial Health Services Plan, which is MSI. And there's lots of examples that were already mentioned of those services, dentists, optometrists. There's many services that lie outside our medical insurance plan. But the government also provides some of those services in other publicly funded settings like hospitals, et cetera. So it's a really complicated landscape in Canada. I think we've already mentioned that. And sometimes leads, because some folks in the private, like that are accessing private care from a dentist or what have you, if they're lucky enough to have health insurance, then they get that. If they're not, they may not. And so that really leads to inequitable care. So our investments here in Nova Scotia is to really ensure that we have a robust enough publicly funded system that's addressing the need of Nova Scotians. So, and that would be sort of in the bucket of what you typically would not have to pay for. So things that you would experience in a hospital setting or a physician offices, et cetera. So privatization would mean that people would be paying out of pocket for services, and they would potentially be queue jumping. That's not what we're doing with private-public partnerships. When we enter into private-public partnerships, we're ensuring that there's equitable access to all. We're using public funding, as I said, to augment the assets and the resources that private companies have, and making sure that it's equitable and fair, so that we're leveling the playing field by increasing more access points, more quality, more services to Nova Scotians that we need to do more quickly. So public-private partnerships enable us to do it faster, but we're still maintaining the principles of the Canada Health Act, which means that our citizens are not paying out of pocket for those services.
Emily White.
So would it be fair to say that the province is using public funds to provide equitable access to services for all?
Audain Barro.
Yes. We would always be using public funds to ensure that what we're using public funds for is ensuring more equitable access to services.
Emily White.
Thank you. I'm going to pass it over to my colleague, Emily Young.
Emily Young.
Thank you, Mr. Chair. Audain Barro, in your opening remarks, I think that you had mentioned about public-private partnerships. You mentioned pharmacies. I think of the pharmacy that's across the street, the pharmacy clinic in Shelburne, that seems to be taking a tremendous amount of people through. I'm wondering if you could tell us more, or if you could even elaborate more on this partnership.
Audain Barro.
Thank you. Thank you for the question. I think it's a really important partnership for access to care in Nova Scotia. Pharmacists are one of the most accessible healthcare professionals that we have, and so by entering into a partnership with the pharmacies and increasing what they can provide to Nova Scotians is actually increasing the services that Nova Scotians get. It sort of stems back to even the packet legislation that we passed last spring enables increased scope of all the professionals. So professionals are now able to, and we're working towards making sure that all healthcare professionals are working to maximum scope of all the things that they're able to do, and that legislation also enables us to bring in others from different parts of the world or different Canada with no barriers. So we're using that as a way to get more practitioners in. So the pharmacy example is that we have ensured that pharmacists are working to maximum scope, and that we are publicly we enter into a relationship where we can provide public funding to enhance that. So it's all about making sure that we're using that private asset in a pharmacy situation to ensure we have more services that pharmacists can do so that Nova Scotians get more care faster.
MLA Young.
Thank you, Mr. Chair. I'll ask this question to Mr. Spinney, and perhaps Department of Health and Wellness may want to comment, but you mentioned health homes. It rolled right off your tongue, health homes, and if you could break it down, like just explain what is a health home, like how does it work, what's it mean for patients, just simplistic terms.
Mr. Spinney.
Thank you, Mr. Chair. The way that we access care is changing, as we've all talked about, and there is different ways, whether they be virtual care, whether they be expanded scope, whether they be the more traditional way of a primary care setting where you go in and see the same family physician time or time again. However, as all of that evolves, what we're learning together is that it isn't so much that you need to see the exact same person all the time. What you need access to is somebody who understands your situation, understands the system, and can help you navigate through it so that you can get the best care possible. That's actually the goal. So we're trying to sit back and look more at what's the intent. The intent isn't to see the same person. And so through that, what we're trying to work our way through right now is better articulating that to the populace and also set up the organization accordingly so that when people come in, whether it be through virtual care or potentially otherwise, if you're not attached to the same person, the same family physician all of the time, that you are attached to a health home that understands your situation, they understand the help that you need, and they understand the system and how to help you navigate through that. And so throughout the province, I don't have the numbers here, but happy to provide them, we have an extraordinary number of primary care collaboration centers already in place that are busy seeing patients every day. And so, as I mentioned, 10 to 20% of the time, the folks who don't have a family physician, the same family physician, when they call in through virtual care, they're sent to these health homes. That's in effect what it is. And so we're trying to do a better job of explaining that in new ways to folks so that they can understand that they are cared for. That is what we're trying to accomplish. They just may not see the exact same person all the time. So trying to make that distinction between what's the real goal of the situation, which isn't to see the same person, but it's to make sure I get the care I need when I need it, and I have somebody that advocates for me and can take me to the place I need to go next.
Emily Young, did you want?
Yeah, I got
okay.
One more quick one, if I can.
Go ahead, Emily Young.
Okay, here we'll throw it. Come away. Back to Mr. Spinney, I guess, or the NSH. We have Nova Scotia Health has several private partners to deliver health care agreements. They have several agreements with, sorry. If you could just tell us more about the agreements that you have in place and the impact they are having at reducing wait lists and improving access to care.
Mr. Spinney.
Thank you, Mr. Chair. So as you mentioned, there are numerous. Somebody said it well at the beginning that, private partnerships are not new. They've been around for a very long time. It's really making sure that we use them in the best way for Nova Scotians, not do they exist or not. And so to that end, just a few of the examples, I guess, that we've been doing over the last little bit is our agreement with Varian. And so Varian is a global leader. They have the market share, the 70+% market share in the world with cancer care radiation equipment. So we've been using that equipment here for some time. Dr. James Robar is a world-leading expert with it, doing amazing things with that. Well, we entered an agreement with them, a 10-year agreement, to do a few things, one of which is to provide Nova Scotians the latest, greatest equipment. And so January 4th of this year, the first person in Canada to receive treatment with the new Ethos units with Hypersight was done here in Nova Scotia, which is pretty cool. And beyond cool, I guess, to explain the magnitude of that, what would typically have taken 20 sessions of radiation can now be done in 5. And so you can just, it's amazing what it can actually do. Something else that they're in the process of doing with us right now is opening a global software development office here in Nova Scotia with a minimum of 60 people that will be in that office to work through some imaging software together. We're actually going to be able to participate in that. So the cancer team will do a better job of explaining how all of those things are impacting the wait lists and the care that people are getting, but I think that paints the picture a little bit. In the case of 18 Acadia Street, otherwise known as Scotia Surgeries, but we really shouldn't be using that name. That's a company name. That is not the facility that the government now owns. We've seen the amount of surgeries for Nova Scotia Health in the past year increase by a couple hundred. So we're over 500 a year now, where we were just over 300 a year ago. And so significant increase there, and some really great patient experience comments coming out of that facility, which there always has been. Like, this has been 15 plus years, so this isn't a new thing, except the government now owns the facility to really gain access to that. People often ask, well, why can they do it? Like, why is that different? Why can they do it? Why can't we do it? Well, we can do it. We are doing it with them. And one of the things, for instance, that's taking place there is it really becomes a center of excellence for particular types of surgeries. Somebody mentioned earlier that sometimes it's the easier ones and the harder ones go elsewhere. Well, the easier ones should be cohorted into one place so that you can become really efficient and that you can get more people through it. So those are two of the examples that we've been up to, with more if we had more time, perhaps.
MLA Young with just over 6.5.
Oh, thank you, Mr. Spinney, and I'll kick it over to MLA Palmer. Thank you, Mr. Chair.
MLA Palmer.
Thank you, Chair. And this is a great conversation so far. I'm madly taking notes here and got so many different thoughts that I've been formulating as we've been listening to our witnesses today. And the only thought that's really coming to my mind a lot is that if we really want to build a system that's truly patient-centered and patient-focused, I believe it's our responsibility to leave no stone unturned to provide the most equitable, best access we can for patients. And I think that's what we all agree that we need to do here, right? So one of the best examples of private-public partnerships that we've seen, and we've been touched on here so far, is the pharmacy care clinics. So I have a couple questions for Ms. Bodnar, and maybe the Associate Deputy would like to give her thoughts as well. But just a bit more specifically, I had the privilege of having the Premier in my area on last week, and we visited a pharmacy care clinic in Greenwood, and got a good chance to hear what's happening there and the access that's creating. So, Ms. Bodnar, could you talk about how, especially in rural areas, how those community pharmacists and the government are working together to fill those healthcare gaps, and talk about the future potential expansion of that, how we can continue to work with pharmacy care clinics going forward?
Ms. Bodnar.
Sure, thank you for that. I think people would be surprised. Those clinics have now delivered in just about 15 months over 160,000 services to Nova Scotians, and that's across the entire province. We have clinics in Yarmouth, Shelburne, Greenwood. We have clinics in Sydney and from Chester and otherwise. But these clinics are creating access that just didn't exist. When we look at other new points of access in the system, whether that's mobile care, virtual care, even the urgent care, these clinics do more than all of those. So these are a really important element to the system, and they're important for patients, and they're important for the system, and they're important for providers. If we want to keep providers, and I mean all providers, whether that be pharmacists or nurses or physicians, they have to want to go to work every day. They have to want to get up and provide that care. And these clinics, utilizing pharmacists to their full scope of practice, is making our members proud again to do what they do. And I think that's going to not only keep our pharmacists here, but it's attracting pharmacists. We were just in London over the last few days, and we had 142 people express interest in coming and wanting further information. We've had 14 people through our expedited process license here in Nova Scotia since January, and another 29 files open. So what we're doing here in Nova Scotia is world leading, and it's making a difference to patients, the system, and to providers.
MLA Palmer.
Thank you. And I have spoken to many pharmacists who have said the same thing, that they've been wanting to do more in their scope for so long, and they are just as much of they're not just allied healthcare professionals. They are just as much professionals as anybody. So I have had those conversations with those pharmacists who are really happy that they have that ability to use their full scope now, for sure. And this idea that we have these public-private partnerships. We talked about, it's not like privatization where we're getting people to pay with their credit card or anything like that. I take that pharmacy care clinic in Greenwood. The people down there aren't walking in the door after they get an appointment saying, is someone going to profit off me today? They're saying, my child has an appointment for their strep throat. I'm glad I have access to that service in primary care. So to your point, it is a success story that I know in my area. I have 2 pharmacy care clinics, and they're really well received. So I do have a question that I think I'd like to ask, I guess, the Department of Health and Wellness. The government's added a lot of new healthcare professional seats in different professions and is building up the infrastructure. Could you speak to the partnership with our post-secondary institutions and talk about how those seats will help create more sustainable healthcare professionals going forward? Could you speak about that?
ADM Barro with just over a minute and a half.
Sure. Thank you for the question. Yes, it's really important to build as many seats. It's part of our recruitment strategy, making sure that we're accessing all Nova Scotians that are eligible and want to go into those health professions by increasing the seats. The other important thing that we're doing with those seats is ensuring that we have seats that are guaranteed for our First Nations and our African Nova Scotian Black populations, so that those populations will see more practitioners that look like them, because that creates a better, safe environment. So we're really pleased that we're able to increase the number of seats, and we paid attention to those elements of equity that are really important as we build our healthcare professional infrastructure in Nova Scotia. So I think we're doing a good job there.
MLA Palmer.
Time, Chair?
50 seconds, assuming you don't do much of a preamble.
Okay. Well, am I known for that or something? No, again, I just want to reiterate, and maybe Ms. Bodnar could touch on this, and maybe I'll just ask in the next round when it comes around. For those rural areas, just to maybe expand and talk about the significant role and how we were able to see how we were going to use pharmacies in the experience of COVID and during the pandemic time, and how we used the pharmacies to help us in vaccinations and different things like that, and how that maybe created a template for how we could work with them going forward. But that makes any sense?
Ms. Bodnar with 12 seconds due to preamble.
I think we'll maybe address this after, but obviously 1.5 million vaccinations in one of the only healthcare centers open during
Order.
COVID.
So the next round will be 7 minutes. I just need to fix this. And it will be the Liberals, MLA DiCostanzo.
Thank you, Chair. And if I may go back to OPOR, I have a burning question, honestly. All we heard today is about all the access points, whether it's pharmacy, whether it's virtual care, and all this is wonderful. But when we decided on OPOR, we did not include them. And the people who are using these access points because they don't have family doctor are the ones that need it the most. It's been 3 years now, some of them, without family doctor. And they've had no record. So they show up at emergency, they show up at a pharmacy, and it is, to me, a liability to the doctor in emergency, to the pharmacist, not knowing their record. But you go this government spent $360 million and not include them. How did that decision come about and why?
Mr. Spinney, I'm assuming.
I'll start. I'm certainly not the decision maker, so I'll defer to others on that part. But what I can say, I think definitively, is that nobody was excluded. We simply said that we needed to start, and we needed to start with the acute system. And so I suspect, again, defer to other decision makers, but that is the natural extension of where we go with this. We just simply needed to start with the acute system, and then rolling it out to those other things, I think, makes 100% sense. In fact, I think that's how we deliver a health home that I talked about earlier. We need to be able to have access for others through that system. And I don't think anybody's going to disagree with that. I think it's really about trying to get there as fast as we can. And that is the change that will take place through data that the minister spoke about the other day at the Chamber of Commerce luncheon as well, is that, but in order to deliver on that, we need to do exactly what you just said. We need those other avenues included in one patient, one person record.
Emily DiCostanzo.
Okay, so I believe the announcement said that OPOR, it's over a 10-year, that $360 million. If you can just tell some timelines, so that first you're starting with this, and that's going to take 10 years. Then when will we have the pharmacists, the virtual care, and everybody else? Would that be 20 years? What are we looking at here before we have access to our records?
Mr. Spinney.
Thank you, Mr. Chair. I obviously don't have a specific time with that, but just to comment on the 10 years, the rollout across the province throughout the 39-plus facilities we have takes 3 years. And so, so the 10 years includes the continued support and evolution of that and the partnership with Oracle. So it isn't a 10-year implementation. The implementation period's actually much smaller than that. And I think that I think you're asking exactly the right questions, and I think that those are the things that that need to be determined over the next while here as we implement, because I think those are the right next steps. It's just a matter of the sequencing of those things, yes.
MLA DiCostanzo.
We need to be honest.
There you go.
Sorry. I think we need to be honest with our population as to when they expect to have that with the record. But another thing that surprised me, that it was when the $360 million was announced for the OPOR with Oracle, not even a week later, there was another announcement of $120 million for the cancer as a different software with Variant. So to me, I said, okay, if OPOR is not good enough for cancer, the whole point of OPOR is to unite 80 systems together. That is just within the hospital system. We have 80 systems. We're trying to do one. Then a week later, we spend $120 million on a different system with a different company. How can you explain that to me?
Mr. Spinney.
Thank you, Mr. Chair. One of the things that one person, one record is aiming to achieve is bringing all those different systems together, like you just said, and it's an extraordinary number, which makes it so complex. And by virtue of having that number, it shows that we're not dependent on only one system. There are other systems involved. In the case of Varian, is the announcement, part of the announcement that you're talking about there, we determined that we would be able to start providing cancer patients their electronic cancer records, I'll say now, immediately. We don't have to wait for a 3-year implementation. And so the province made the decision to engage with them to get that rolling now, fully understanding and appreciating that it could integrate with the OPR system. And so that's what we're seeing right now. And so in many of the hospitals in the province, you'll start to see, if you haven't already, some posters on the wall talking about AREA and some software that you can use that allows you as a cancer patient to log in, see your cancer treatment plan. You can do your scheduling and interact with your care provider. That didn't exist, and we didn't want to wait 3 years for that. And so we've done that now, and that's being implemented and rolling out through the province. So that's why. It wasn't in contradiction to something. It was simply much faster to be able to start a piece of this journey and not at the expense of that larger system, because it would be able to be integrated.
MLA Di Costanzo with 44 seconds.
I'm still a little puzzled that the variant system is faster and delivered much faster, but we didn't use it for the rest of the system. It doesn't make sense to me that there is a system that is faster and it achieved more than OPOR, and we went with it after we announced the OPOR. So I don't know how you can square that one.
Mr. Spinney, 12 seconds.
Mr. Chair, much smaller group. There's 50,000 people in Nova Scotia with cancer, and it's not the 1 million populace that we need to deal with the 80-plus system. So that's the 12-second answer.
And it was 11 seconds. You did very well. Thank you very much. MLA Barro.
Thank you. Ms. Rose, it's been said here a number of times this afternoon that P3 arrangements have always been with us, nothing new, and so it's only a question of not whether or not we're going to have them, but how we're going to use them. But I want to say that I don't think that's the question at all. I think the question is, with the very serious problems we have in our healthcare system, from wait times to access to all different forms of care, is the best path the path of contracting private service-providing entities to provide the services we need? It seems to me that's the question that's in front of us, and I wonder if you would speak to the Coalition's position on that question.
Ms. Rose.
Yeah, thank you for the question. The Coalition's position, we do believe in strengthening our public health care system, not in the form of contracting it out to private providers. Sorry, can you repeat the second part of that question?
MLA Barro?
Yes. Is the best path the path of turning to private service-providing entities, agencies, companies to deal with the big problems that we have? Is that the path we ought to be on?
Ms. Rose?
We think no, it's not. Ultimately, these processes, I mean, it does range, whether we're talking about private hospitals or different centers or travel nurses or Maple and the virtual care, all of those vary greatly. And some things, of course, have always been private. But we do believe that the better option for Nova Scotians to get the care that they deserve is to keep it in the public system and strengthen the public system instead of opting for more expensive options that don't always provide the, I guess, solutions that they do. I mean, it would be great if they did, and if they did, maybe I would be out of a job for everything to work, super smoothly the way it does. But I think realistically, we should be looking at reinvesting in our public health care system.
MLA Barro.
Well, I'm thinking back a couple of years to the position that that the Coalition took about the partnership with Maple when it was first entered into. The Coalition was a very clear voice. This is the wrong direction in which to go. Is this still the Coalition's position? And given the couple of years' experience we've had, have you been led to change that, or is it something that's modified, or do you still think that this is the wrong path?
Ms. Rose.
We still stand by that things should be kept within the public system. In saying that, obviously it's no one person, no one Nova Scotians, like we don't blame them for obviously accessing the Maple app. I use it myself. I don't have a family doctor. I've only lived here for a couple years. But largely we do believe in keeping it within the public system as just an overall statement.
Emily Barro.
Then related to that, I wanted to ask you, what is the Coalition's thinking then on Nova Scotia Health's partnership with Think Research in the development of the Your Health app?
Ms. Rose.
It remains kind of the same as the, it would depend a whole lot. You know, we would love to see Nova Scotia Health kind of develop it on its own, but I think that's a little bit unrealistic when we talk about developing an entire app. That obviously takes a lot of time and a lot of money, so of course we understand that different routes have to be taken.
Emily Barro.
Thank you. So I want to pursue the same question in a different form. Ms. Mullen, to you, because I think it's important to be clear on the fundamentals of this. The union, not very long ago, when the QE2 redevelopment began, said that the P3 arrangement was like taking money for our health care and turning it into another yacht for a CEO. So can you expand on why the union thought that, and is that still the union's position on using P3 as the backbone for the expansion of the healthcare system?
Mrs. Mullen.
Thank you for the question. And definitely the union still believes in publicly funded, publicly delivered health care. We've seen a number of issues go by the wayside that were in a private, and again, private for-profit partnership. And we've seen projects fail. We've seen projects not completed, not even started under that route. And we have our members who work directly within those systems, seeing what happens when there is a private and again for-profit system come in to try to deliver services, and whether that's just the day-to-day service within the organization, whether it's laundry, you know, and they're bringing it back in-house because we know, they know, I do believe the employer knows that our members do a better job of delivering services. So it's definitely our position to continue along. We lobby with the Healthcare Coalition and both the Canadian Healthcare Coalition, which is offering and working towards the federal pharmacare program that will help keep folks out of the ERs, which again, it's a prevention model. The dental care that being offered to seniors and to youth, those are all preventative measures that are publicly delivered. You know, I have seen the opposite of the Maple, where Maple is coming in and being offered to employees of post-secondary as a benefit package that they have to pay for. So it is similar to an advertising scheme that, yes, you get 2 free, but your next trial is like the Columbia Records, and you're going to be paying forever.
Emily Barro with 39 seconds.
Well, then I want to ask you, Ms. Mullen and Ms. Rose, both. Do you then have concern with the expansion of the role of private entities in dealing with their problems, that this is leading us on a path towards a 2-tier system?
Mrs. Mullen, 20 seconds.
Thank you very much, and I do believe that's exactly where we're heading. The very reason we want to see some transparency on these contracts, to be able to show Nova Scotians that it is a benefit, should not be difficult. If it is for the public benefit, it should not be hidden.
All right, order. And is it MLA Palmer?
Thank you. I just want to go on the record and say I actually bought 20 Columbia House CDs for 99 cents once, so thank you for bringing that up. Ms. Bodnar, could you finish your answer about the experience of the pharmacies during the pandemic and how that sort of provided an example for future partnerships? You were answering that question.
Ms. Bodnar.
Sure, absolutely. So I think we started with the fact that when many organizations were closed and access to care was limited during the pandemic, all of the pharmacies remained open and the pharmacy staff there. So I think the public's relationship with pharmacies started to change a little bit when they recognized the skill set and the services available. And that's just translated into a bigger demand and bigger interest in building on that relationship. I mean, these are community health practitioners, which even patients who are unattached to other healthcare providers are often attached to their pharmacist. And they have a wealth of information and history on which to build and provide care and provide that navigation to other parts of the system. So, since that time, we've been able to, open these clinics. We're focusing those clinics in areas of highest needs. I think the previous committee testified to how those selections were done based on the registry and ensuring that they were spread throughout the province. So, yeah, I think it's just something to continue to build on. And again, I'll reiterate with, most of primary care is delivered through private entities, publicly funded through private entities, whether that's physicians or dentists or optometrists or pharmacists. It's only care in acute facilities. And so I think we need to ensure all of the things we talked about before: access, equity, transparency, cost, standards of care. And if we can do that, how the money flows, I think, is a little less relevant than ensuring we have those standards, cost effectiveness, and access.
MLA Palmer. Oh.
Thank you, Chair. Thank you, Ms. Bodnar. I'll pass it on to my colleague.
MLA Barkos.
Dr. Audain, you've been so quiet over there. I think I'll ask you, what do you think of partnerships like Halifax Vision, where surgeons can use their facilities to cut down on surgical wait times? And how do you see it helping doctors provide better and faster service?
Dr. Audain.
Sorry, I'm not sure if I completely understand your question.
Halifax Vision.
MLA
Sorry.
Barkos.
Halifax Vision is allowing surgeries to take place in their facilities, and I'm wondering how you, well, it cuts down on the surgical wait times for anyone needing that service, and I wonder how you see it helping doctors provide better and faster service for patients.
Dr. Audain.
I think my understanding of Halifax Vision is it would fall into a similar category as Scotia Surgery. As far as I know, those services are still publicly funded, and it would allow more patients to receive eye care that they otherwise wouldn't be able to receive if they were just waiting on their ophthalmologist to be able to treat them in the hospital system. Does that answer your question?
MLA Barkos.
Well, I guess sort of. But I'll just move on because we're down to 10 minutes. I'll move on to the next one. 3 minutes?
3
of
minutes.
course, 3 minutes. How do you anticipate partnerships like this to further improve efficiency and effectiveness of healthcare delivery in Nova Scotia?
Dr. Audain.
I think that for me, most of these partnerships that we're talking about are still, I would consider, publicly funded in that the patients aren't having to pay out of pocket for these services. But I would also caution that they're there to allow patients to have access to services that they're otherwise struggling to have access to. So to my earlier point that in instances where patients have no access to a physician at all, it's better to have access rather than no access, but the ultimate goal should be attachment. And the idea of a healthcare home is what ultimately we should be striving for, in that it's a collaborative model where the patient's information is in one place and it's not scattered in different silos around the province. So we should still be striving to utilize healthcare workers, whether it's pharmacists or nurses and nurse practitioners, to their full scope of practice, but not in this way where it's in silos and not integrated in a way. So it's important that we have these measures right now so that people have access that they otherwise wouldn't have, but we shouldn't lose sight of the long-term goal to provide attachment to everybody in a way that is, that should be the standard of care.
MLA Barkos with 1.5 minutes left.
Thank you, and I think we've heard this from the department in regards to doing a home care and trying to one patient, one record, things like this. Is I think from listening to you, kind of nails that all down to what you would like to see happen. So I think I'm going to move to. Actually, this is a good question because a lot of people, so I would like to know if you could explain to anybody, these millions of listeners out there today, how NSH and the Department of Health and Wellness works together to come up with decisions regarding how they spend their money on what kind of like public health funding. So that would be to the
ADM Barro.
Thank you for the question. We work very closely together to ensure that we're on side so that the NSH, who would be the operational arm of the health system, would understand what they need in that space. And what we work through is, business cases where they would express what they would need and for what benefit, et cetera. Then the department would work with that submission. And actually, it's the ultimate decision of Treasury Board and Cabinet sometimes to ensure that that's what government wants to invest in. So we have a system where we work very closely. Health Authority comes up with the type
Order.
of initiatives.
Thank you. That ends of all the questioning. So what we'll go is we'll go for closing statements. I will start with Mrs. Bodnar. Do you have any closing statements?
Thank you. Just quickly, again, I think we really need to understand the concept of private versus public healthcare and really focus in on those elements that I mentioned earlier. I think if we can ensure access, equity, transparency, cost effectiveness, and standards of care, then we will have achieved the healthcare system that we want.
Thank you. Dr. Audain?
Thank you again for the opportunity to participate today. It's an important topic, and while we want to ensure Nova Scotians have good access to care, when it comes to private-public investment, we must step carefully. Private sector involvement should complement the goals of the public system for primary care and other specialty services, including universal access, connection to a health home, continuity of care, and so on. It should not come at the expense of equitable access for Nova Scotians or create health human resource challenges for the public system. Ideally, we need to stabilize primary care in the publicly funded system so all Nova Scotians have good access to the care they need. This will help relieve pressure on the system. Thank you.
Thank you. Mrs. Mullen?
Thank you. Thank you. And to elaborate on that, again, we want to stop the exodus of staff to these private organizations, whether it's an agency for whatever private practices are taking our members away. The other side of it is we reiterate the fact that it is private for profit, and therefore, while they may not be paying for those services out of pocket, they are paying with it income tax. Here in Nova Scotia, it is their cost. So we also need to make sure that those agreements are transparent and accessible to show the members of this province.
Thank you. Ms. Rose?
Thank you for having us here today as well. Ultimately, while the Health Coalition stands by keeping our public system fully public, or as public as it can be, and introducing the parts that are private back into the public system or into it for the first time, public-private partnerships are clearly here and perhaps here to stay. And so for that, we would love to focus on transparency with the public and also putting resources into keeping services and employees back into our public system to benefit all Nova Scotians.
Thank you. ADM Barro?
I would just like to thank everyone for the very important topic today. I would just like to reiterate that we believe and continue to strengthen our publicly funded healthcare system, and we believe that robust and transparent, equitable partnerships with private industry is one way that we can ensure services that Nova Scotians need and deserve faster.
Thank you. Mr. Spinney? One more. There we go.
Thank you, Mr. Chair. So thank you for the opportunity today. I really appreciate these sessions. The transparency, what we're all striving for, couldn't agree more. And I'd like to publicly thank for the millions that are tuning in. I heard earlier, all 30,000 plus people working at Nova Scotia Health every day. We are very proud of the work that we do. We're proud of our teams, and we're grateful for the opportunity to be helpful. Thank you.
Thank you. This concludes this portion of asking questions. What I will do is go recess until 2:48, then we'll be back to deal with our business. So we're in recess. Order. Okay, we have some committee business. All right. On April 26, 2024, we had a letter from Department of Health and Wellness written in response to a request for information made to the Office of Healthcare Professional Recruitment during the March 19th. It was forwarded to anybody. Does anybody have any comments? Oh, MLA DiCostanzo.
Just to thank Judy, she did a lovely job with our letter.
She always does a great job.
Yes.
Okay, next item. This is a reminder. At the last meeting, I remind everybody that we will be having an agenda setting meeting in June 11th. Each caucus is asked to ensure they send the list of proposed topics to the clerk by Wednesday of May 29th. July 9th. There's a proposed alternative witness to represent Nova Scotia Health Cancer Care Program if the topic is cancer screening program. Just want to remind people we're coming up to summer and we're having some issues with it, getting witnesses. Do you want me to finish first before you? Did I miss something the way you're looking at me?
Saying, if you want to explain, you can just read that part.
That's what I was going to do. Okay, thanks. So the approved witness is Cancer Care Program Senior Medical Director Dr. Hollenhorst. Okay, Executive Director Jill Flynn. They may not be able in June or August, or sorry, July or August, and have asked whether other senior staff and medical leads could appear in their place. So what's committee's view on that? If we decide not to do that, then we'll have to try and figure out what the July topic is. So MLA DiCostanzo?
Just trying to remember what other doctors were. What I was interested in is Dr. Sean Isles. Is she coming in? Or is she one of the ones who's not coming
No, the two are Dr. Hollenhorst, which I probably said that wrong, and Executive Director Jill Flynn. Those are the two that are unable to come in July and August. So
these two can come.
they can, yeah. So it's the two doctors from Nova Scotia Health that are unable to come in July and possibly August. Ann Yule, which is IWK Health, is able to, and Dr. Sean Isles is able to. So the question is are we fine with those two? Just a sec, MLA LeBlanc.
Yeah, I think if there's senior staff and working in the cancer screening program, I think that would be fine. It'd be, it might be nice to see if we can get one who's administrative and one who's clinician, if possible. But I think senior staff is great.
Agreed? Yeah, that's great. Okay. It's agreed. Okay. The next meeting is July 11th. Or sorry. I want to skip June for some reason. I'm telling you. It's June 11th, 2024, 1 to 2 p.m. agenda setting. Is there any other business? Meeting adjourned.